So it's really a pleasure for me to be here. My name is Millie Das. I'm a clinical associate professor at Stanford University and also chief of oncology at the VA in Palo Alto. And the title of my talk today is Targeted Therapy for Rare Non-Small Cell Lung Cancer Drivers. And I'll be specifically discussing NTRK, RET, and HER2. Next, please. These are my disclosures. Next. Okay, so just to start, and I think Luda showed a similar slide. This is borrowed from one of my colleagues at Stanford, Dr. Joel Neal. This is just a depiction of the targetable driver mutations in non-small cell lung cancer. Over the last 10 to 15 years, we've really been able to fill in a greater pieces of this pie chart here, and we've been able to identify driving genetic alterations in our patients with lung cancer. And of course, you've been hearing about a number of these alterations, and Luda just spoke about KRAS G12C mutations. I'm going to be talking about some of the more rarer mutations, and you can see those highlighted here in red. So NTRK fusions, HER2, and RET rearrangements. Next slide, please. So I'll start with NTRK. So NTRK fusions are really found across multiple cancer histologies. We see them in various subtypes of brain cancers, in thyroid cancer. We do see them also in salivary gland tumors and secretory breast cancer, which are rarer cancers with higher frequencies of these NTRK fusions. Of course, we see them in lung cancer as well. And it's estimated that between 1,500 and 5,000 patients in the US are going to harbor an NTRK fusion. And I think the significance of this is that we do now have a number of FDA-approved therapies that specifically target NTRK gene fusions. Next slide, please. So this is the data that we have with one of these drugs called Larotrectinib, specifically in lung cancer patients. This was a small study of only 12 patients, but again, because NTRK fusions are seen in less than 0.5% of lung cancer patients, it's going to be really difficult to be able to perform a larger size study. Nonetheless, in this small study, what we're seeing is that the overall response rate of Larotrectinib was quite high. It was 75%. And you can see here in this waterfall plot that patients really did seem to have tumor shrinkage, including those patients with brain metastases. The response rate in those patients with brain metastases is 67%. On the right is the swimmer's plot, just giving us an idea of the duration of response. And you're seeing a duration of treatment anywhere from 1.8 months to 35.2 months. So, of course, we're continuing to get data from our patients being treated with this drug, but based upon this data, the FDA did approve this drug. Next slide, please. Adverse events are shown here, mostly well tolerated overall. You can see fatigue, dizziness, some GI side effects such as nausea and constipation were noted, mostly grade 1 in most patients. Anemia was also noted. Some of the other less common side effects that I think are of note are pyrexia, which is essentially fever, or edema. So just to be aware of these potential side effects. Next slide, please. So the FDA approved Larotrectinib in November 2018 for solid tumors harboring NTRK gene fusion, and this really represented the second tissue-agnostic FDA approval for the treatment of cancer. And that's after, of course, pembrolizumab, which many of you may be familiar with, which is a PD-1 antibody that's been approved really regardless of tumor type for patients with PD-L1 expression level of greater than or equal to 1%. Next slide, please. The other FDA-approved therapy is Entrectinib, and this is the data looking at a pooled analysis of 3 early phase trials. 10 different tumor types were represented in this trial, and what you can see is that the lung cancer patients are represented in this sort of bluish purple color on the waterfall plot on the top part. 31 of 54 patients had an objective response, including 7 patients with a complete response and 50% with a partial response. The most common adverse events with this drug included increased weight, anemia, and what they note as a cognitive disorder, which is mostly just sort of difficulty concentrating or a reduced attention span. Next slide, please. So it was based upon this data that the FDA approved Entrectinib in August of 2019 for solid tumors harboring an Ntrec gene fusion. And I just wanted to also point out that this drug, Entrectinib, has been approved in our patients with ROS1 positive non-small cell lung cancer. So this drug also has activity against ROS1 and has been approved for that indication as well. Next slide. So a summary of NTRK targeted therapies, we know that NTRK is an uncommon mutation in non-small cell lung cancer representing less than 0.5% of our patients. However, the significance is that we do have at least 2 FDA-approved NTRK inhibitors now, Larotrectinib and Entrectinib. They're approved for NTRK-positive solid tumors that include non-small cell lung cancer. Overall, these drugs demonstrate a high response rate, and they seem to be very well tolerated. Next slide. Moving on now to RET alterations. So we know that RET alterations are seen mostly in lung and thyroid cancers. And there are a number of different FDA-approved multi-kinase inhibitors that target various kinases and other receptors, including RET. And you may have heard of some of these drugs because they're approved in various other malignancies. Examples are Sunitinib, Sorafenib, Vendetinib, Cabozantinib, Regorafenib, Lenvatinib, and Entrectinib. So these drugs target multiple receptors, including RET. In lung cancer, in RET-rearranged lung cancer, they've really had limited clinical benefit, and the thinking behind why that may be the case is just that there's the doses are limited in terms of off-target toxic effects of these drugs, and so perhaps we're just not able to administer these drugs at the highest efficacious dose, and that may be why we're not seeing great efficacy. But I'm going to show you some examples on the next slide, please. So this is the use of off-label RET inhibitors in our RET-rearranged lung cancer patients. You can see here on the left the data with Vendetinib. Probably more encouraging than some of the other the data that we have with some of the other drugs. Overall response rate here was 53%. With Cabozantinib, we're seeing a response rate of 28%. And then with Entrectinib, we're seeing a very low response rate of 4%. So again, I think the worry here is that these are not selective RET inhibitors, that were the doses needing to be limited by the toxic effects of the fact that these drugs are targeting other kinases and receptors. Next slide, please. So Selpercatinib as a selective RET inhibitor that's been studied specifically in RET-positive non-small cell lung cancer. This was a study of a little over 100 patients where the investigators found a pretty impressive overall response rate of 64%. And I think what's even more impressive is the fact that this drug seemed to work quite well within the brain. The intracranial response was 91%, and it was noted in 10 out of 11 patients with brain metastases. The most common adverse events were hypertension and increased AST. So overall, pretty well tolerated drug. Next slide, please. Median duration of response with Selpercatinib was 17.5 months, and it was really based upon this data that the FDA approved Selpercatinib as an option for our RET-rearranged patients. And this was just approved last year in May of 2020. Next slide. The other RET drug is Pralsetinib. So this is another selective, highly potent RET inhibitor. In early phase clinical trials, it was compared against some of the other multi-kinase tyrosine kinase inhibitors, and you can see that the selective activity against RET with Pralsetinib was really superior compared to some of these other tyrosine kinase inhibitors that were kind of multi-kinase inhibitors. So I think this drug showed a lot of promise in early phase development, which led to later phase trials. Next slide. So this was a phase 1/2 study involving 233 patients with RET positive non-small cell lung cancer. Again, you're seeing pretty impressive response rates. So there were 92 patients with prior platinum-based chemotherapy who had an overall response rate of 61%. About 29% of patients were treatment naive, and these patients had a slightly higher response rate of 70%. Overall, again, the drug seemed to be pretty well tolerated. The most common adverse events were noted to be neutropenia, hypertension, and anemia. Next slide. Shrinkage of brain mets was also noted with the use of pralsetinib, as I showed you with selpercatinib. So with pralsetinib, shrinkage of brain mets were seen in all 9 patients with measurable intracranial metastases. 5 out of 9 patients had an intracranial response per RECIST criteria, with 3 complete responses. And so the FDA also approved pralsetinib in December of 2020. So we now have these 2 options. Next slide. So a summary of RET targeted therapy: RET fusions are seen in 1 to 2% of non-small cell lung cancer. When we do have a patient who has a RET alteration, of course, we worry about brain mets given the higher risk of brain metastases. What's nice is that we do now have these 2 FDA-approved drugs, selpercatinib and pralsetinib, which both seem to demonstrate good brain activity and are now targeted options for our patients with RET rearranged non-small cell lung cancer. Next slide. And then finally, moving on to HER2 targeted therapy. So there are currently no standard therapies targeting HER2, the HER2 pathway in non-small cell lung cancer. Of course, you probably know that there are approved therapies in HER2 positive gastric and breast cancers. And it's been really challenging in lung cancer just because there's been really no clear correlation between HER2 overexpression, amplification, or mutation. So there's various kinds of HER2 alterations that can be noted. And I think one of the struggles is really trying to figure out, what is the exact HER2 alteration that can be targeted? Is it overexpression? Is it amplification? Or is it mutation? And we know that when we see these various I think subtypes of HER2 alterations, they're not mutually exclusive. HER2 mutations are noted in about 2 to 4% of lung cancer patients. They're mostly exon 20 insertion mutations. HER2 amplification is noted in 10 to 20% of our patients, and overexpression in anywhere between 2 and 38% of our patients. So, and I think this is what is one of the major challenges in really being able to come up with targeted drugs is how do you design a trial, and are you going to be studying it in patients with mutations or amplification or overexpression? We know that HER2 alterations can represent both primary driver and mechanisms of acquired resistance. Next slide, please. So this is just a schematic of the various HER2 targeted drugs that have been in clinical development. So you're probably familiar with Trastuzumab and Pertuzumab because they're approved in breast cancer therapy. So these are monoclonal antibodies that target HER2. We also now have these antibody drug conjugates, or also known as ADCs. And examples of these are Trastuzumab deruxtecan and TDM1. And I'm going to be showing you some data with these 2 agents on subsequent slides. We also have this group of therapeutics, again known as the tyrosine kinase inhibitors, or the TKIs. We have pan-HER inhibitors that include afatinib, dacomitinib, and Neratinib. And then we have these novel HER2 TKIs that include poziotinib and pyrotinib. And we know that overall HER2 mutations, again, represent anywhere between 2 and 4% of our lung cancer patients. And there's a higher prevalence of these mutations in specific subgroups, including patients with adenocarcinoma histology and in never smokers. Next slide. Overall, it seems that the TKIs are minimally effective in our patients with HER2 alterations. You can see really pretty low overall response rates. In the studies that have been done with some of these pan-HER inhibitors, you're seeing response rates anywhere between 0% and 19%. And so there's a lot of interest in being able to come up with novel HER2 targeted tyrosine kinase inhibitors. And one such drug is Poziotinib, which is a more potent inhibitor of both EGFR and HER2 exon 20 mutations. And it's being studied in an ongoing phase 2 trial. Next slide. So this is the data that was presented just earlier this year, looking at this drug Poziotinib in our patients with both EGFR and HER2 exon 20 mutations. And what I wanted to just focus on, of course, is the HER2 exon 20 cohort, which is cohort 2. And what you're seeing is an overall response rate of close to 30% in this patient population. And so this is certainly higher than what we're seeing with some of the other pan-HER TKIs. And I think, of course, we're waiting for additional data. And so there's a lot of interest in further looking at this drug in this specific subset of patients. Next slide. Neratinib is another TKI that targets HER2, and there's a few different studies in clinical development. These are phase 2 trials looking at HER2 mutant non-small cell lung cancer patients, and we have some preliminary data, which I'm going to share with you on the next slide. So we have the PUMA study and the SUMMIT study, and these are the survival curves here. And what we're seeing, overall response rates are not great with this drug. Again, kind of ranging from 0 to 14%. In this study, the Neratinib was also evaluated in combination with Temsirolimus, which is an mTOR inhibitor. And even with that combination, overall response rate was noted to be 14%. So this is just preliminary data. We'll, of course, wait additional data. Next slide. TDM1 is an antibody drug conjugate, and I think that this drug has shown promise in our non-small cell lung cancer patients with HER2 alterations. And so this is just data looking at the use of TDM1 in a phase 2 setting. There were 49 patients, and they included patients with HER2 expression that, and basically they were divided into 2 different cohorts. The immunohistochemistry IHC 2+ and 3+ cohorts. And what we're seeing from this data is that there were no responses seen with TDM1 in the IHC 2+ patient cohort. We did see a response rate of about 20% in the IHC 3+ cohort. And the clinical benefit rate was 30% in the IHC 3+ cohort. And so this is, I think, interesting, and many of us are using this drug off-label in our patients with HER2 altered non-small cell lung cancer. Next slide. And then, of course, we have Trastuzumab deruxtecan, which is another antibody drug conjugate. And I think this is probably the drug that's showing the most promise. And this drug now has an FDA breakthrough designation based upon this DESTINY-Lung1 trial. So this was a trial involving unresectable or metastatic non-squamous non-small cell lung cancer. These patients had to have relapsed from or be refractory to standard therapy. They had to have measurable disease and good performance status. There were there were 2 different cohorts here. Cohort 1 involved the HER2 overexpressing patients. This was again measured by IHC and divided by IHC 2+ or 3+. Patients received Trastuzumab deruxtecan at a dose of 6.4 milligrams per kilogram IV every 3 weeks. There was also a cohort 2 here, which involved HER2 mutated patients. And again, the drug was given at the same dose and dosing schedule. So this is the interim analysis of cohort 1 that I'm going to show you now. Next slide. So you can see here the waterfall plot showing some responses to this drug. The overall response rate was 12%. So not super exciting. But what I think is more notable is the fact that a large percentage of our patients who received this drug did achieve a stability of disease, particularly in the IHC 3+ cohort. You're seeing a 60% stable disease rate here. And so the overall disease control rate, which includes really all the complete responses, partial responses, and stable diseases, was 80% in the IHC 3+ cohort and close to 70% in the overall patient cohort. So again, I think really exciting, and we're hoping to get more data with this drug. And I mentioned to you that we do have this FDA breakthrough designation for this drug based upon this data. Next slide, please. So a summary of HER2 targeted therapy, we know that the existing and emerging small molecule tyrosine kinase inhibitors are only modestly active. Poziotinib, which is one of the novel HER2 targeted TKIs, does demonstrate increased activity against HER2 mutated non-small cell lung cancer compared to other TKIs. And of course, we're waiting for their data. There is a potential role for antibody drug conjugates, and specifically for TDM1 and for Trastuzumab deruxtecan. And so again, we're excited about these drugs. We are using them in clinical practice whenever we can, and hopefully we'll continue to get more promising data. Next slide. So my overall conclusion from today's talk is that there's a number of rare driver subsets in non-small cell lung cancer that are being identified on the next generation sequencing panels that are being done for our patients. They're really now part of standard of care for our patients with lung cancer. And as we're getting these panels back, the results of these the results are going to indicate potentially targetable mutations, including some of these rare driver subsets. And of course, the significance is that we have a number of novel targeted therapeutics that can offer our patients better outcomes. And I think this is all consistent with President Biden's Cancer Moonshot Initiative, where the goal is really to accelerate research to make more therapies available through precision oncology. So really to look at individual patients and be able to offer them the best therapy possible with the least amount of side effects. And I think, this is really kind of the goal here is to accelerate that bench to bedside process. So making discoveries in the lab and translating them quickly into better drug and treatment options for our patients. So really exciting times in lung cancer. And I do hope that as we give this talk in future years, that we're going to have more and more genetic subsets that are identified in non-small cell lung cancer. And we're going to have drugs that target those specific subsets. Thanks so much.